All right, in this clinical explainer, we're going to tackle dengue fever, a condition that's becoming more and more significant around the world. Everything we're covering today is based on the fantastic work of Dr. Mohammed Al-Naji Mohammed. So let's dive in. So right off the bat, let's get our bearings. Dengue is a viral infection, sure, but what's really crucial for us as clinicians is its potential to get much, much worse. It's actually in the same class as other viral hemorrhagic fevers. Think yellow fever, Lassa fever, and yes, even Ebola. That classification alone tells you we're dealing with a pathogen that demands our full attention and some very vigilant monitoring. Here's our game plan. We're going to walk through 5 key areas. First, the etiology and transmission. Then, we'll look at the clinical spectrum of the disease. After that, the really key warning signs to watch for. Then, diagnostics. And finally, we'll wrap up with the principles of management. Okay, first up, etiology and transmission. Let's get to the bottom of the virus itself and how it gets around. So what exactly are we dealing with here? Well, the dengue virus is an RNA virus, and it belongs to the flavivirus genus. You'll recognize that family. It's the same one that includes Zika and West Nile. But the critical piece of the puzzle for us is the vector, the Aedes aegypti mosquito. Knowing this is absolutely vital when you're taking a patient's history, especially when it comes to any recent travel or exposure in an outbreak area. And this number right here, 7 days, this is a vital clinical time frame. The typical incubation period is about a week. So when you have a patient who comes in with a nonspecific fever, asking them where they were and what they were doing for the past 7 days is absolutely essential. That 7-day window is so often the key that unlocks the diagnosis. Moving on to our second section, the clinical spectrum. You know, dengue isn't just one thing. It's a whole range of illness, from a fairly straightforward fever all the way to life-threatening severe disease. We actually classify this spectrum into 3 distinct stages. Most commonly, a patient will present with dengue fever without any warning signs. The critical branch point, the moment we need to pay extra close attention, is when they start developing those warning signs. That's what signals a much higher risk of them progressing to that third category, severe dengue. Recognizing this potential progression is, frankly, one of our biggest responsibilities. So what does that classic, uncomplicated case of dengue look like when they walk into your clinic? Well, the combination of symptoms is pretty unique. You're looking for a high fever, a really bad headache that's characteristically retroorbital, that classic pain behind the eyes. Then there's the deep muscle and joint pain, sometimes even pleuritic pain, some facial flushing, and often a maculopapular rash. You might even see some minor bleeding signs like petechia or a nosebleed, even at this early stage. You know, the intensity of that muscle and joint pain is so bad that dengue has earned a pretty grim nickname, breakbone fever. This isn't just some minor ache. Patients will describe it as this excruciating, deep, relentless pain in their bones. When you hear a patient describe their pain like that, your suspicion for dengue should go way, way up. This brings us to section 3, and honestly, this is probably the most critical part of patient management, the key warning signs. This is where our clinical vigilance can literally change the outcome for a patient. These are the red flags you absolutely cannot miss. We're talking about significant abdominal pain, vomiting that just won't stop, an enlarged liver, and any clinical signs of fluid accumulation. Think ascites or a pleural effusion. These aren't subtle findings. They are the direct result of significant capillary plasma leakage, which is really the hallmark of dengue starting to progress towards its severe form. So, what's happening under the hood when a patient progresses to severe dengue? Well, pathologically, it's basically a form of disseminated intravascular coagulation, or DIC. This kicks off a consumptive coagulopathy, leading to a massive drop in platelets, thrombocytopenia, and a huge risk of spontaneous severe bleeding. This is the mechanism behind that hemorrhagic fever name. And the stakes here are incredibly high. For patients who develop severe dengue, a really significant number, somewhere around 20 to 30%, so about 1 in 4, will go on to develop dengue shock syndrome, and that is a state of circulatory failure and a major driver of mortality. This statistic just hammers home why catching those warning signs early is so incredibly vital. Okay, section 4, diagnostic investigations. Let's talk about how we confirm what we're seeing clinically and how we monitor the patient's progress. Your standard blood work, a full blood count, and liver function tests will often give you the first objective clues. The classic pattern you're looking for in dengue is leukopenia, a dropping white cell count, a progressive drop in platelets or thrombocytopenia, and raised aminotransferases, which tells you the liver is involved. Seeing that combination in a patient with a fever, especially if they've been in an endemic area, is highly, highly suggestive. Now, with specific diagnostic tests, Timing is everything. In the early days of the illness, say from day 0 to day 5, we're trying to detect the virus itself. The best tests for that are the NS1 antigen test, which is fast and pretty reliable, or a nucleic acid test for viral RNA. But after day 5 or so, the amount of virus in the blood starts to drop, and the body's immune response really kicks in. So in that later phase, we switch tactics and test for IgM and IgG antibodies to confirm the infection. And finally, Section 5, Principles of Management. Our whole approach here really boils down to one central idea. And that idea is supportive care. The treatment for dengue is entirely symptomatic. This means meticulous fluid management to counteract that plasma leakage, really careful monitoring of their hemodynamics and their urine output, and being ready to provide blood products like platelets or packed red cells if they have severe bleeding. And this is a really important point to understand and to communicate to patients and their families. There are currently no specific antiviral medications for dengue. We can't directly attack the virus. And that fact just reinforces why our entire strategy has to revolve around supporting the patient's body through that critical phase until their own immune system can finally clear the infection. So we'll leave you with this question to think about in your own practice. For a disease where we have no cure, no magic bullet, how does our ability to spot those warning signs early and accurately, that abdominal pain, the persistent vomiting, the fluid accumulation, how does that skill transform from just a part of the diagnosis into the single most critical, life-saving intervention we can possibly offer our patients?